resources, and exploring working with a diverse patient population. Today I would also like to briefly describe our Kaiser Permanente Healthy Bones program. I have no disclosures for today. Now today I'm going to give you lots and lots of information in this very short period of time, but all the resources I'm going to talk about are on the National Bone Health Alliance website, and I'll carefully walk you through how to go to their site and access the tools I talk about today, step by step at the end of this presentation. The steps will actually be on slides that you'll be able to go back and look at. We'll also have time, like Debbie said, at the end of the presentation for questions. And I'll also give you my email address and my phone number if you'd like to contact me later. I'm very happy to talk with you later. Now I want to clarify that I'm not at all an expert in the field of diversity. But I was born and raised in Southern California. I've been a nurse working for over 40 years with a very diverse population of patients. My own marriage, I'm in a marriage of a mixed ethnicity. So I've experienced firsthand the melding of diverse cultures. When I first started in this field of osteoporosis, as some of you who know me, it was many, many years ago, we thought this disease happened just to elderly, thin Caucasian women. It was a woman's disease and almost always Caucasian women. That's been a very difficult stereotype to break. But we've now learned that osteoporosis is an equal opportunity disease among a world of very diverse people. In fact, I'll be in Singapore next week for the International Osteoporosis Foundation Conference. Osteoporosis happens to everyone. So I'm hoping today that I'll increase your understanding and enthusiasm for working with diverse patients. I truly believe we are a beautiful world of diversity, but often in different cultures, different gestures, different styles of body language, and different ways of speaking give different messages. As an example, nodding the head or a head wobble may mean the patient understands what you're saying, not necessarily that they agree with what you're saying. And this is important to remember, especially when you're talking about medication as an example. So I'd like to share some tips that help me, and they may be helpful to you. It's important that we approach the patient in a more formal manner, since we as Americans tend to be more informal. I recently had an elderly person ask me why no one puts a handle on her name any longer. By saying the word handle, what she meant was the Mrs. in front of her name. In other words, when she'd go to the doctor, a lot of younger people, the nurses and the medical assistants, called her by her first name. When I go to the doctor with my 89-year-old mother, it is a bit awkward when they call her by her first name. So there's a bit of respect that comes with age, and especially within other cultures. Another thing that we can try and do is to tolerate those gaps between questions and answers, especially if there is a language barrier. So don't be offended or act offended if the patient interrupts you to ask a question. Also, keep in mind that eye contact in some cultures is interpreted as rude or shows disrespect. Or, on the other hand, it may mean that you are dishonest if you don't look someone directly in the eyes. So that may be something that you have to figure out. But just follow the patient's lead. But if the patient is uncomfortable with eye contact, instead of sitting directly across from him or her, try sitting next to them. That might be something that will work better. Keep in mind that it's common in some cultures or countries to only go to the doctor when you are sick. So our idea, and this is very prevalent within the Kaiser system, we focus a lot on screening or preventive health. That idea may be new to someone who's used to only going to the doctor when they're sick. In other words, there may be a distrust of Western medicine, possibly a lack of communication on the patient's part if they see, especially if they see someone who offers alternative care, like let's say someone goes to an herbalist when they are sick. So keep those type of things in mind. We also often have a fast-paced model of care. Like, for example, our appointments can be every 15 or 20 minutes. And that doesn't always allow the patient time to tell their entire story, especially for those of you working with elderly patients. You know that oftentimes they want to spend a lot of time talking. So that's difficult. It's also a comfort to the patient to see a healthcare professional or a nurse, someone that's of their own culture. Now, obviously, that's not always possible, but it would be a help if it is possible. Or if you speak any of their language, even if it's only a small amount. In California, Spanish is a language that many of us know, maybe even just a little bit. It offers a comfort, and it's helpful to try and speak that patient's language with them. Keep in mind with your elderly patients from other ethnicities that their children or even their grandchildren often are their caretakers and are with them at their appointment and often are interpreters for them. This is a huge advantage, but it also might interfere with transparency. As an example, maybe the grandmother may not be as open because her grandson is translating her words and she may not want him to know everything. So keep that in mind. Above and beyond all, you're going to work at trying to build trust with your patients of different ethnicities, build that trust with you. I'm going to give you a website to go to for some excellent ideas and resources. And I'm also going to let you know that we have many handouts and patient letter templates already translated for you. We have these handouts and letter templates in Spanish, Chinese, and Vietnamese. So hopefully some of this will be languages that will be helpful for you. Now the website I'm recommending is at the bottom of this slide and also the previous slide. And it offers many tips for communicating across language barriers and working with interpreters and interpreter services, which I highly recommend if you haven't tried already. I've taught classes with an interpreter, literally standing next to me almost word for word, interpreting what I'm saying. I've also had interpreter services on the phone. So for office visits, I've had the interpreter on speaker interpreting as I'm working with the patient. So I highly recommend interpreter services. But please take advantage of the handouts and patient letter templates that we already have translated for you. That's a big, big service that's already taken care of for you. I also would like to spend a few minutes talking about how patients learn. For those of you that may have been at the National Osteoporosis Conference this year, we listened to Barbara Schreiner talk about this exact topic. She talked to all of us about having a style or preference of gathering information. There's 3 types of learners. She talked about the visual learner, and that's the person that needs to be shown things to learn. So I'm that type of learner. She talked about the auditory learner. That's the person that learns best by being told things. And then there's the kinesthetic learner, and that person needs to move around in order to learn. As an example, if you're an auditory learner, you may need to listen to podcasts. You like to listen to podcasts. This is how an auditory learner may gather their information. The artist Charles Schulz, he's an example of a visual learner. So a kinesthetic or an active learner would be like Michael Jordan or Kobe Bryant. Those are those people that move around a lot, or they build things, or they fiddle or fidget when they're sitting still. These people have to move in order to process information. So let's translate that into our patients. So we're usually giving our patients lots of information at one time. They've come right off the DEXA scan machine. We're reviewing their DEXA score, their We're possibly talking to them about their low vitamin D score, telling them they have a new osteoporosis diagnosis, and how do we manage this information so that patient isn't overloaded? Let's try and give that patient just 3 pieces of the most important information first. So the order of this information, in other words, the sequence, is important. You also want to try and stop all the distractions for your patient's full attention. In other words, that background noise, try not to have your cell phone vibrating, your desk phone ringing, someone walking in to ask you a question. The light that's in your room is important. So if there's too much glaring light or reflecting light, these are examples of interruptions that may interfere with your communication with your patient. These all distract the patient and interrupt the learning that you're giving to that patient. The patients may not say anything or even be aware that something physical is interfering with their understanding of what you're saying. It's also important to know that how we teach a patient is how we like to learn or how we were exposed to learning. As an example, if you say, just give me the bullet points and I'm good to go, that may be how you will teach. So that may be how you teach your patient. That may work well for you, but that doesn't always work well for the individual style of learning for that patient. Another example may be you may talk a lot. You may talk too much, and if the patient is a visual learner, you may lose them. So in your office, offer a variety of modalities, lots of visual cues for the visual learner. If your patient's in your office for a 20, 30, 60-minute visit, let them get up and stretch. Encourage them to move around. This will enhance their learning. It also keeps your patient awake and alert. It's recommended to show or tell your patient what you want them to learn 6 different times in 6 different ways. Now, this can take the form of a handout, verbal instructions, a poster that they look at on the wall, maybe a PowerPoint slide if you're showing them something, but 6 different times in 6 different ways. Now, this is obviously a challenge, but it could be a goal for you. It could be something that you think about the next time you have a visit with your patient. We now know that information must make sense to the patient. And we have learned, and you've probably noticed, especially working with different age groups, that different generations learn differently. So for our veterans, these are our patients born within the years of the 1930s and 1940s. They're considered our traditional learners. They may not contradict or disagree with you. They don't like to be singled out. They did not learn technology, but they're not necessarily technophobic. They don't like to learn in groups. So keep this in mind. We tried this at our medical center to have a group visit model, and with this age group, it didn't work that well. They're older, so you need a larger font when you're developing your handouts. Keep this in mind. Now, our baby boomers, this is me. Those are those that are born within the years of 1950s and 60s. We're independent learners. We like interaction, but we dislike role playing. So we'd like a team project that didn't involve role playing. And we're the group that you can use bullet points and move on. And our next group is the Generation X, and this would be my adult children. They're born in the 1960s through the 1980s. These group of people are self-reliant, fiercely self-reliant. They're more skeptical and silent. They're very techno-capable. They grew up with all the technology. They like feedback. They're adaptable. They like a more informal relationship. They learn by hands-on and playing games, if you've noticed. Gamification, it's called. They like to use bullets also, but when you're developing your handouts, use lots of white space, and graphics on handouts is helpful for learning. Now, keep in mind with your patients that sharing stories can be very helpful and an important way to teach. It helps, especially with our elderly patients and especially with other ethnicities. It helps to break down resistance, and it taps into patients' memories. Especially if you're sharing stories back and forth with a patient, it finds that person's own wisdom, and it brings meaning to what you're talking about. So always think of a story that you can share with your patient. I found this to be a fascinating slide because it shows us how much our patients are remembering of what we tell them. Maybe something as simple as having them repeat back to you what they have understood you to have said to them may help improve their memory by 70%. So something so simple has truly amazing results, and that's something you can just do in a minute as they're walking out the door. So now I want to shift gears and just take a minute to quickly review our Healthy Bones program for those of you who may not be familiar with us. I would really like to suggest to you to learn from the many years of combined experience of those that have already started fracture liaison service programs and encourage you to not try to reinvent the wheel. The NBHA site has a wealth of information for you. FLS programs have been figured out for you already, and all of their information, and I mean many FLS programs are on their site. You just need to find out what will work for your organization. When we first started our FLS in about the year 2004, we had problems like everyone else. Our hip fractures were costing our organization a lot of money. We realized that patients were not getting treatment for osteoporosis after having a fragility fracture, and this was a nationwide problem and still is in many cases. There was no consistency among our medical centers. We have 14 medical centers now. Each one had a different way of running a program. When we looked at coding and ran the numbers, we were shocked to find out how many millions of dollars was being left on the table each year. And we were performing poorly compared to other organizations in our HEDIS measure. So originally, we built the current HEDIS measure at the time, which was very important when we started. We wanted to minimize patient handoffs. We wanted to minimize return visits, especially for those elderly patients, because as you all know, they always have transportation issues. And we wanted to limit the impact on our primary care providers. So by using mid-level providers, such as we use nurse practitioners and physician's assistants, we call them our Healthy Bones Care Managers, we were able to take it out of the hands of the primary care providers, but they can still be kept in the loop if they want to stay informed. So the main advantage of using mid-level providers is that they can diagnose and treat and document and code. Now that doesn't mean that you can't do this without an NP or a PA. I'm a nurse, but I'm not a nurse practitioner, and when I first started, we used a nurse protocol. I was housed in an orthopedic department and was constantly, literally chasing the orthopedic surgeons for their signatures for Fosamax. Now mind you, this was back in the day before medical records. The electronic medical records. So some areas now use virtual visits, and they call patients after their visits. So there's many ways to have an FLS program. It doesn't have to be exactly the way we do it. I know sometimes people are afraid of us. They think, oh, you're such a big, huge system with this enormous electronic medical records. Well, we didn't have this big, huge system with a big, huge electronic medical records when we started. So you can do an FLS program in any system. We have a centralized workflow used by our Healthy Bones Care Managers. Once again, those are our nurse practitioners and our physician assistants. Our workflow is important so that we are giving standardized care across all of our medical centers. And we make sure that we have clear workflows with detailed accountabilities. It's really important for there to be a centralized team of players to own the program program, and this one I'm going to repeat again. It's really important for there to be a centralized team of players to own the program without people taking responsibility and being accountable for the patients, for the members of your program just won't work as well. I think that's really a big key to success. Like I mentioned earlier, we utilize as much support staff as possible, even volunteers. So a volunteer may be able to walk your patient from, say, as an example, the orthopedic department to the DEXA scanner, or maybe they can simply stuff envelopes for anything you can get a volunteer to do saves you time. So utilize any support staff that you can. And we actually try to incorporate this concept we call a just-in-time idea into every workflow we have. So a one-stop shop idea or concept where everything can be done after the DEXA scan at one time is what we strive for. As an example, when a patient has an orthopedic appointment and we notice they need a DEXA scan, we can say, let's get your DEXA scan today. And if possible, we walk them over to the DEXA scanner. If they feel like it's part of their appointment, they're more likely to stay and have it completed. Or another idea is when a woman is having her mammogram and it's noted she needs a DEXA scan, it's offered to be done during the same appointment as her mammogram, and there's no extra co-payment. So let me take a minute and walk you through our workflow. So a patient has a DEXA scan. Almost all of our DEXA scan machines are housed near where the Healthy Bones care manager sits, sometimes literally across the hall. The patient then, after having the DEXA scan, walks over to the Healthy Bones care manager immediately, right after the DEXA scan. The Healthy Bones care manager then reviews the DEXA results with the patient. The patient's also given some education about osteoporosis, calcium, vitamin D, exercise, fall safety. Medication is ordered if needed, and also the labs are ordered. Now keep in mind, everything we have is in one location. So the patient then walks over to the pharmacy, picks up their medication, walks over to the lab, has their labs drawn. We also have osteoporosis classes that the patient's referred to. The Healthy Bones care manager documents and codes for this patient, and an email sent to the primary care provider to keep them in the loop. Now in our SNFs, skilled nursing facility, the geriatricians and the nurse practitioners and physician's assistants there are responsible for this process. So our program has proved to be successful. In the year 2012, we did an analysis and looked at some numbers, and we found that we were able to reduce our hip fracture rate by about 50% lower than we expected. So that translated into 1,587 hip fractures and 387 lives saved. We saved about $52 million in hip fracture costs. We had about $7 million in revenue, and we were the first in the nation at that time on the HEDIS measure. So we try to keep it simple. We order DEXAs preventively on our women age 65 and older, and our men age 70 and older. All our fracture patients, except for fractures of fingers, toes, face, or skull, no matter what the reason for the fracture. Originally, we used to do it just on fragility fractures, but now we order it on all fractures. Age 50 and older, both men and women, and on those patients who have been on bisphosphonates 5 years and longer. We start medication on those that need it. We monitor adherence, and we evaluate at 5 years. We try as often as we can to utilize our support staff as we different departments that our program may be housed in, since our program itself does not have much support staff, such as administrative assistants. Again, I would like to suggest to you to not try and reinvent the wheel. You just need to find what will work for your organization. We also utilize both in-reach and outreach to our members, which is supported by our electronic medical records, but can also take the form of a letter or a phone call. or an automated phone message, which I'll discuss with you today. So let's talk about some ideas for tools for success. The NBHA has so much information on their website, and once again I'll walk you through how to access these tools. We try to keep our providers well educated about all the current issues having to do with osteoporosis awareness. On the screen in front of you is an example of a document we created that listed many of the common facts, figures, and statistics frequently quoted about osteoporosis and fractures. At one point, people were telling us, you tell us so much about osteoporosis, we'd like to know all of that, have it in front of us, and have documentation of where that came from. So we created a document for them. There also is a sample of an ISCD, that's the International Society of Clinical Densitometry training, that was provided for our primary care providers. Our NPs and PAs are ISCD certified. We feel that this is very important. We create brochures and posters for lectures and health fairs. The one on the slide explains our Healthy Bones model of care and has a matching poster, which is a nice display like for a conference a provider may be attending. We provide 3 main sets of working guidelines. We have our Kaiser Permanente Clinical Practice Guidelines, the Kaiser Permanente National Guidelines, and then we have our Healthy Bones Care Manager Guidelines. These are really our working guidelines. These are the ones we tailor especially for our nurse practitioners and physicians assistants. These are all on the website. We provide what are called FAQ sheets, which answer frequently asked questions about individual topics, usually whatever is a current topic, such as an atypical femur fracture as an example. At one point, we created a clinician FAQ for DEXA Z-scores when we realized that many of our primary care providers were unfamiliar with the specifics of the Z-score on the DEXA scan report. We also provide job aids, which are step-by-step guides for carrying out a process. As an example on the screen, you'll see a FRAX decision tree. Many of our job aids are in the form of decision trees or workflows. So anything that people need refreshing their memories about, they can simply pull up the job aid. As I mentioned earlier, we use every opportunity and every point of service to outreach to patients. Even if you don't have electronic medical records yet, we have opportunities with letters, phone calls, automated phone messages that you might be able to look at. We also encourage May, which is National Osteoporosis Awareness Month, as a time to increase awareness at our medical centers. And we send out ideas, and we usually have 1 week when all of us try to participate in osteoporosis events together during that week. We provide many education handouts and a customized booklet from Cranes covering many education topics such as calcium, vitamin D, fall safety, how to have healthier bones, just as examples you see on the screen. And once again, most of these that you see on the screen have been translated into other languages. Similar to our provider frequently asked questions about current topics, we also provide the same for members. So we have member FAQs also. And they usually correspond to the clinician FAQs. So when we have created a clinician FAQ, there usually is a matching patient FAQ. We've found that having consistent member communication coming from each of our programs at each of our medical centers is most effective. So that standardized communication is very, very useful. As a result, we created standard patient letter templates for the Healthy Bones care managers and primary care providers to send to their patients. We also have matching after-visit summaries, which are given to the patient after they've seen, after they've had their visit. And it's a piece of paper that's taken home with them that they can review later. It's also available for the patient online. What is nice about these letters is that they're very simple and easy to understand, which is what you want for general member comprehension. They have also been approved from a legal standpoint. And then for our automated phone message system, we've created scripts for recording. One of our latest phone message recording is for patients who have not picked up their medication. Now keep in mind, everything I'm talking to you about is on the NBHA site, and it's already been done for you. We also have this great set of bones, which is an excellent way to actually show patients what their bones feel like normally, and then what they feel like when there's bone loss. So one bone weighs normal, it's heavier than the other, and when the patient picks up both the bones, they can feel like what one feels like when it actually has osteoporosis in, and they're always just amazed. The ordering information is posted for you once again on the NBHA site if you're interested in purchasing a set, and there's actually a Kaiser discount price available. We found much success using decision aids, what we call decision aids, with our patients. The ones we use came from a talk given by Dr. Michael Lewicki. You've possibly heard of him. He's well known in the field of osteoporosis. The care manager or provider is able to use this as a visual aid to help the patient make a more informed choice about whether or not to take medication. This is especially helpful for shared decision making, and these two are examples of decision aids. So what we do is print them out, laminate them, and then it helps them to last longer. So an example of how a decision aid would be used is showing the patient, as an example, the seatbelt decision aid, and ask, would you ever drive without wearing a seatbelt? And almost everyone says, oh no. And then showing them that wearing a seatbelt reduces the risk of serious injury and death by 50%. Treatment with bisphosphonates, like the seatbelt, reduce the risk of fractures by 50%. I usually share a story of my husband who had an accident quite a few years ago with a seatbelt on. His car flipped upside down. He got sideswiped by a garbage truck, and his car flipped upside down. And he walked away with only a small bruise from where the seatbelt pulled on his shoulder when he was hanging upside down. So the seatbelt kept him from having a serious head injury or possibly being killed. Well, the same is true with the bisphosphonate medication. Even though there's a small risk of a side effect, like there was that small risk of the seatbelt giving him the bruise, that small risk of the side effect of the bisphosphonate, like an atypical femur fracture or osteonecrosis of the jaw, it could prevent a hip fracture in the event of a fall or an untimely death, like the seatbelt kept him from head injury or possibly being killed. So these decision aids have been very, very helpful and effective for us with our patients. So why do we use all these tools and resources? At Kaiser, each hip fracture costs us at least $35,000 to $40,000. If you're just looking at the economics, we save one hip fracture for every 100 patients treated. One hip fracture for every 100 patients treated is a lot of money saved. We save one life for every 25 hip fractures avoided. This is priceless. There's just no way of, this is priceless. And to be able to preserve member independence with aging is also priceless. My own mother has severe osteoporosis. She's fallen more times than I can begin to tell you, but she's in one of our Healthy Bones programs, and even though she hasn't always been compliant with her medication or her vitamin D through the years, We've managed to keep her from having a hip fracture. She lives in her own home at age 89, and to me, this is priceless. So let's take a look at a summary with all the pieces working together, because we need all the pieces working together. And let's not forget how important medication adherence is to successful outcomes. And I know medication adherence, especially lately, is a big piece of this working together. I'd like to give you my contact information and then walk you through navigating the NBHA website to get to our patient materials. And let me do what I can to help you. I'll admit that I'll respond much quicker to email if you email me on the AOL address as opposed to the KP address. And I'm probably the only person left in the world with an AOL email address, but it works well. I've had it for forever, and everybody knows that address, so I'll probably keep it. But if you email me there, I'll respond much quicker. The phone number is my cell phone, and I'm perfectly fine with you calling or texting me on the cell phone. If I don't answer right away, I'll get back to you as soon as possible. Okay, let me walk you through the steps on the NBHA site on how to navigate to the tools. I also want to stress again what a wealth of information there is on this site. Don't think you can just quickly scan through all of this. Go pour yourself a cup of coffee and plan to stay a while. Now, I'm giving you a link. It's sort of a quick access, a shortcut, as opposed to going to nbha.org. You can always go to nbha.org and explore the site and find lots of FLS information. But for our tools, I'm just going to give you a shortcut. And if you copy and paste this link, this will be much quicker for you. So take this link, and these green arrows, if you follow them on each of these slides, it'll get you there real quick. Copy and paste this link, and then it will take you to a screen where you need to either, if you've already created an account, you log in here, or you create an account. Now, you'll need to create this account with your email address and a password. But keep in mind, it's free, and they don't send you any spam email. It's perfectly fine. Don't worry about this. Once you do that, it will take you to a page that looks like this. And all you need to do is simply scroll down this page until you get to a screen that looks like this. And you'll see the green arrow pointing to where you need to go. It says Additional Kaiser Permanente Tools. And you click on this red part that says Kaiser Tools, and then this will take you to our site. Now, keep in mind that you'll see all of our tools, and you can click on anything you'd like to open and look at, but each one of these links will open many documents. So once again, plan on spending some time here. So it's not like each one of these links is one document. For example, where it says Member Education Part 1 handouts, inside there is many, 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 many documents. So it's a lot of time that you're going to spend here. But I want to thank you so much for your time and attention. Once again, contact me if you have any questions. And I do believe we have time for questions.
Great. Thanks, Kathy. This is Debbie again. For those of you who would like to ask a question of Kathy, please go to the question piece in the GoToMeeting and enter it there. Okay, so the first question we have is, how do you track your patients and prepare to meet their needs during a consult?
So after the patient has had their DEXA scan, the DEXA scan is literally given to the patient by the DEXA tech. Not given to the patient, given to the Healthy Bones care manager. And because we have electronic medical records, the Healthy Bones care manager opens up the electronic medical records and can look at the patient's entire records. So at that point, the Healthy Bones Care, she reviews the medical records before the patient comes in, and there's a questionnaire that the patient fills out before they have the DEXA scan completed, and that questionnaire is very thorough, and that questionnaire actually is on the website, so you can take that questionnaire if you'd like to and use that questionnaire. So between the questionnaire, having the medical records available, and then just talking with the patient when they come in, it's a very thorough that initial office visit is very thorough, and they're able to get all of the information that they need in order to make a thorough assessment and evaluation.
Our second question is, you mentioned the child or a grandchild as the translator for an older patient, and that may impact communication in terms of the patient feeling comfortable in sharing or answering questions. How have you dealt with that in the past?
So I'm most comfortable with an interpreter, because then you know that everything is validly being interpreted. But oftentimes, I think the advantage of having a family member, as an example, grandmother brings daughter to an osteoporosis class, then it's almost a 2-for-1 because of the osteoporosis running in the family. Then the daughter can also hear the information. But oftentimes, especially if it's a grandchild that's there, I've found that grandma doesn't always want to say everything for the grandchild to hear. So I always bring in an interpreter. And sometimes if it's a child, I just have the child wait in the waiting room, because oftentimes they just won't say everything in front of their other family members. So bringing in an interpreter is, you're going to get more valuable information.
Great. One of the other listeners said that it was a great idea to tie in follow-up with mammogram or another appointment, and wanted to see if you had any ideas or suggestions on how this could be done in an open system.
Good question. I've always worked in the closed system, so I'm not as familiar with how you do coding and how the co-payments and how your payment system works. Debbie, maybe you have a better answer for that. For us, it works very well. We simply have the test done at the same time. But I know it's not quite as easy in the open system, because everything isn't right there. Your coding is different. Debbie, maybe you can answer that question.
Sure. No, I'd be happy to add in just what I've heard from others in the FLS program who are in the open system and who have dealt with the issue. A lot of it is obviously relationship building with the other doctors or other departments, and setting up ways to coordinate, whether it's appointments as well as alerts, whether it's in the EHR or getting updates that are automatically sent from medical records to the different offices, so that it can be coordinated. But the big thing that I've heard is really developing relationships, with the doctors or the offices that would be dealing with the follow-up appointments, and then looking at ways to piggyback from that point on.
Great. Thank you, Debbie.
The other question that I see right now is dealing with the older patient and the issue of medication adherence, as well as dealing with issues regarding concerns about taking an additional medicine, and any suggestions that you have had or resources that have made this an easier process.
That's a very good question, and we do run into that, where oftentimes patients will say, I'm just not going to take one more medication. And once again, we try and use our decision aids to help show the patient how important this is to take this medication. We oftentimes try and just tell them, you know, just the value of this medication. This is an ongoing problem, especially with our older patients. Oftentimes they just feel like they don't understand why this is important because they're feeling fine. We talk about osteoporosis being the silent disease, and they aren't feeling pain, especially if they haven't had a fracture. They've just had this test done as a screening test, and they've come up with a low T-score, and they're not understanding why this is important. So our decision aids have been very helpful for us, but sometimes even talking to them about their history. Oh, did anyone in your family have a fracture? Anyone break their hip? Oh yeah, my mom broke her hip, or my grandma broke their hip. Sometimes finding out what happened to mom or grandma. Oh yeah, grandma died within a few months after breaking her hip. Or, oh yeah, mom broke her hip, and then, yeah, she had to use a cane for the rest of her life. Or, oh yeah, she went to a nursing home then. Sometimes just going through their family history and finding out what happened when someone broke their hip or had a broken bone, sometimes that will kind of stimulate in their mind, oh yeah, no, I don't want to end up like them. So those patients that have broken a bone, we try and catch them right away, because when the fracture is fresh in their mind, then they're more apt to, likely to want to take the medication. So we have something that we call our lists, and these lists are refreshed daily, and this is through our electronic medical records. And our Healthy Bones care managers can see that day when someone has had a fracture. And so we try and grab that patient right away when they're in the hospital or when they've gone home, call them right away, get that DEXA scan done, that medication started, grab them while they've had the fracture when it's fresh in their mind. We want to reinforce to them that we don't want them having another fracture. But that is a problem. And then we also, through our electronic medical records, another one of our lists are those patients who don't pick up their medication. So if they've been prescribed the medication within 7 days, if they haven't picked up their medication, then we call them. We have a list who tells us who hasn't picked up their medication, and we call them to find out why they haven't picked up their medication. Sometimes it's something as simple as they haven't been able to get a ride to pick up their medication. Or sometimes then they talk about their fears of taking the medication. So we do follow up to try and increase our medication adherence for those patients that haven't picked up their medication.
Thank you. Okay. The other question that I'm seeing right now is, what languages are your materials available in, and how do you identify the best resources to use with different patient populations? Yes, that's two questions in one.
Okay, so the first one, we have patient materials available in Spanish, Chinese, and Vietnamese. And I think we picked those languages because our medical centers were situated in areas where the demographics, we had the patient demand for those languages was the most, and that was the reason we picked those languages. And then could you repeat the second part of the question for me, Debbie?
Yes. How do you identify resources that are beyond what you have developed as part of Kaiser to include in your program?
I'm not sure I'm understanding the question. So maybe I'm thinking, like, as an example, we use CRAME's booklet as a resource, and what we did was we had them personalize it for Kaiser. So CRAME's is a booklet that CRAME's is a company that makes educational educational resources, and we went with them. We went through the booklet and personalized it so that it said exactly what we wanted for patients, and then it used our Kaiser name throughout the booklet. So that was an outside resource. Otherwise, what we do is we develop the handouts within our regional office. We have education department in our regional office. And then everything is vetted, approved by not only our regional office, but we have a Healthy Bones core team that consists of an endocrinologist, a family practice physician, a clinical consultant, and an education person. So it really, our education pieces jump through quite a few hoops. But an outside resource, probably the only thing, education piece that I can think of is our CRAMES booklet.
Great.
I hope that answers the question. I'm not 100% sure of the question.
Okay, great. Well, thank you, Kathy. And I want to thank everyone for joining us today for our Fracture Prevention Central webinar. As I mentioned, today's webinar will be available on Fracture Prevention Central as well as NBHA's YouTube channel, and you will receive an email with links to both. Please do not hesitate to get back in touch with NBHA as well as Kathy, who had shared her email information if you have any further questions. And we hope you will take advantage of the other resources on Fracture Prevention Central. Thank you all, and we hope you have a good afternoon.
Thank you.